I will start by the first session in diabetes mellitus, classification and diagnosis of diabetes and genetics, actually, which is a very, very important. This is a part from my preparatory course. And don't forget that my tools, files, and videos are not for redistribution. It is for your personal use only. And actually, this is an interactive presentation. So any question at any time are welcome. Please stop me and do your comment or do your question at any time. And as I mentioned, diabetes mellitus represent 68 questions from the final exam, which contain 200 questions. This is the main bulk for the final exam. Today, inshallah, I will cover the diagnosis of diabetes according to the NICE guideline, according to the WHO, IDF, and the American Diabetes Association, which is important. And actually, I will give a lot of data, a lot of information, but I will mention that this is important for the exam and another data for your clinical practice and so on. So don't hesitate yourself by this data. If you did not require all of this data, just focus on what I will mention about, which is important for the exam. The genetics for type 1 and type 2 diabetes mellitus is very important and very, very repeated in the previous exam. At least 1 or 2 questions from the genetics in every year. Modi diabetes is very, very important in each year, in each exam. They will ask about 3 to 4 questions related to the Modi diabetes. So 1 question related to the genetics, 1 question related to the diagnosis, 3 to 4 questions related to the Modi diabetes, and also neonatal diabetes, which is important in mitochondrial diabetes, and genetic cause of severe insulin resistance, which also is another very important thing. So from the first session, this session, you will see at least 6 to 8 questions in the final exam. So I will cover this from the Oxford Handbook, and don't forget that I will start from this page to this page, and each discussion, at the end of each discussion, I will announce about what I will cover in the next week. So try to prepare yourself. If you need to pass easily, please, after studying the current session, please read the next session from the Oxford Handbook. At least reading, and inshallah to be with me in the course. And actually, as I mentioned, I will give this notes for each subscriber in my course at the end of module. Today, this is the summary of today's session. This is the most important for your exam. This is the summary, and I will announce about it in the end of this session again. So it is very important to know the diagnostic criteria of diabetes mellitus according to the NICE. And actually, all society recommend diagnostic criteria regarding the fasting blood glucose, a 2-hour post-oral glucose tolerance test, or random or hemoglobin A1C. And you need to be familiar with the cutoff point for diagnostic this biochemical testing. In fasting according to the NICE, in normal less than 6.1 millimole per liter. A 2-hour post-oral glucose tolerance test in normal less than 7.8, and hemoglobin A1C in normal according to the NICE is less than 42 millimole per mole. And of course, a diagnostic criteria for diabetes fasting more than 7, a 2-hour more than 11.1, random more than 11.1, hemoglobin A1C more than 6.5 or 48. This is a diagnostic criteria for the NICE, and actually the American Diabetes Association have a different cutoff point for fasting and normal hemoglobin A1C, which is different than these numbers. This is the most important. And another very important thing to know that pre-diabetes, weight loss by lifestyle modification is the main line for the management of the pre-diabetes, not medication. Weight loss by lifestyle modification. In factors that affect hemoglobin A1C is a very, very important for the final exam. Don't forget that blood transfusion will cause falsely decrease hemoglobin A1C, And another one, which is a very repeated question, is carbamylated hemoglobin, which is in a patient with a chronic kidney disease hemodialysis, which will cause forceful elevation of the hemoglobin A1C. And actually, in the previous exam, they asked a question about the percentage of elevation, forceful elevation of the hemoglobin A1C, which is about 5 to 10%. This is just a sample. I will give a hint about this in more details later on. And don't forget that glycated albumin and fructosamine will reflect the glycemia in the preceding 2 to 3 weeks, but hemoglobin A1C will reflect the glycemia in the previous 3 months. And this actually is a question in the previous exam. Don't forget that steroid can cause diabetes mellitus, but if you have steroid and tacrolimus, usually tacrolimus is the cause of development of a new onset diabetes mellitus, and this is a very, very, very repeated question in the previous exam. And inheritance of type 1 and type 2 is very, very important, especially if the mother is type 1, the risk of inheritance is about 1 to 2%. If the father is type 1, the risk is 3 to 6%. If the father and the mother is type 1 diabetic, the risk is different. In the exam lab, they answer it, the risk will be 25 to 40%, and this is a very important to answer it as an exam lab in the SC exam. But you will see another source, they mention it may be about 10%, and I will cover this in the my discussion. For type 2 diabetes mellitus, monozygotic twins risk is more than 60%, 60 to 100%. This is another very important question. If the father or the mother is type 2 diabetes mellitus, the risk will be 25% for the offspring. Modi diabetes is very, very important. It is autosomal dominant condition. And don't forget, this is a very, very important and very close for the final exam. If you see exam scenario, a pregnant female, and it is a MODY, it is usually a glucokinase. In the exam, MODY diabetes in the exam with a pregnancy, usually glucokinase, which is not required treatment except during the pregnancy, may require insulin therapy, and I will cover it later. This slide is very, very, very important. In MODY diabetes, we have HNF1 alpha for alpha glucokinase 1 beta. And in the exam, they will ask 3 to 4 questions related to the MODY. You need to pick a clue for answering the question. You need to pick a clue for answering the question. If you see low renal glucose threshold, it is HNF1 alpha. For example, if we have a case scenario and they mention a question, the patient blood glucose is about, for example, 7 or 8. If you have a question, a case scenario like MODY diabetes mellitus, and they ask the blood glucose is just mildly elevated, around 140 milligram or 150 milligram, or for example, 8 millimole per liter. And there is a glucosuria. This is a usually HNF1 alpha. If they have a question, a case scenario, and there is some sort of neonatal hypoglycemia and macrosomic baby, it is HNF4 alpha. If there is a mild stable fasting hyperglycemia without microvascular complication during the pregnancy, it is glucokinase. And actually, in the previous exam, they ask about the glucokinase rule in the glucose metabolism, which is leading to phosphorylation of glucose. This is a question in the previous exam. And if you have a renal cyst, it is usually HNF1B. So you need to know the clues for answering each MODY. HNF1 alpha, low renal glucose threshold, low CRP, no, there is a vascular complication, and sensitive sulfonylurea. And I will cover it in more details later because it is very important. In neonatal diabetes, this is a diabetes diagnosed in the first 6 months of the life. It is not type 1, it is monogenic diabetes, it is a neonatal, it is maybe autosomal dominant or autosomal recessive. And actually, in the final exam, they usually have 1 or 2 questions related to the mode of inheritance of a specific disorder. They may ask about the mode of inheritance of mode diabetes mellitus. It is autosomal dominant. They may ask about question related to the pseudohypoparathyroidism. They may ask about the mode of inheritance of men, for example, and so on. The mitochondrial diabetes inherited through the maternal, and they usually associate with sensorineural deafness. So if we have a case of diabetes mellitus with sensorineural deafness, we should suspect mitochondrial diabetes, and they may ask a question about the mode of inheritance, which is maternal inheritance. And the management, this is a very important for mitochondrial. We should assess cardiology because by echo, and audiology assessment is very, very important to detect sensorineural deafness. Another very important one, Dr. Mahmoud, هل رقم usual in the final exam, they usually will not ask about the mode 1 or mode 3. They will ask a question about HNF1 alpha for alpha glucokinase, HNF1 beta. This is the most important. In all previous questions, they ask about HNF1 alpha glucokinase and so on, not mode type, not mode 1 or mode 3 or mode 2 and so on. This is old names. The most important is HNF1 alpha for alpha glucokinase 1B. The lipodystrophy is abnormal fat distribution. It is severe insulin resistance, and I will cover it in more details later on. At the beginning, don't forget Elliot Juslin paragraph about self-management education in diabetes. He mentions that the diabetic who knows the most live the longest. So education for patient is very, very important for everyone. Let's start by the first question from the toolbook. In the final exam, you need to prepare yourself from today about solving how to solve the question. If you see a question like this in the final exam, how to solve it? At the beginning, you have no time. It is a 100 question to be solved in 3 hours. So each question, just few seconds to solve it. Don't waste your time by reading question like this. At the beginning, please look to the question head. Which one of the following biochemical cutoff point are diagnostic for diabetes based on WHO? So answering this question, we can answer it without reading this scenario. There is a lot of questions in the final exam. You can answer the question by reading just the head. And another important, reading the head from the start will be sufficient to search for the clue for answering it. For example, if you read the head of the question and ask about the best next step in the management, you need to know the diagnosis and how to manage it. So it is very important to read the head of the question like this. And if you can answer it without reading the case scenario, you will save a lot of time. If not, you will need to focus on how to answer this question. So they ask about the cutoff point diagnostic criteria for diagnosis of diabetes according to the WHO. One plasma and some question best of 5, we can exclude some option like this. They ask about the diagnostic criteria for diabetes mellitus. 1 hour plasma glucose more than. Is it diagnostic criteria? Actually, no. 1 hour plasma glucose on oral glucose tolerance test, we should ignore this value. So option A is incorrect. Fasting plasma glucose more than 6, actually, we mentioned that the diagnostic criteria of fasting should be more than 7. The fasting more than 7 in asymptomatic patient, 1 abnormal reading, is it sufficient for diagnosis of diabetes mellitus? Of course, no. A random can be used as a single value if there is osmotic symptom. But the fasting in asymptomatic patient, 1 value cannot diagnose diabetes mellitus. All society recommend at least 2 value, abnormal 2 value to diagnose diabetes mellitus, except random with osmotic. A random more than 8.5 in asymptomatic, no, this is not correct. Random more than 11.1 with osmotic symptom, yes, we can diagnose diabetes mellitus by random blood glucose more than 11.1 with osmotic symptoms. So this is how to solve the question in the final exam. So please prepare yourself from today to solve a question like this. And this is from the Atoll book. Another question from the on examination 2022. If you look, what does this result indicate? This is a patient with oral glucose tolerance test, 45, strong family history of diabetes mellitus, fasting 5.9, 1 hour 10, 2 hour 7.6. What is the answer? Is it diabetic? Is it impaired fasting? It is combined impaired fasting and impaired glucose. Is it impaired glucose? It is a normal result. Which one? So don't forget this. 1 hour we should ignore this value. 1 hour is not a diagnostic in all society. We require fasting and 2 hours. 1 hour is a diagnostic for GDM. Not, and don't forget that even for the GTM in NICE, don't depend upon 1 hour. In 1 hour is diagnostic for GDM according to the American Diabetes Association recommendation. So it is very important to know this. In 2 hours 7.6, is it normal or not? A 2 hour post glucose tolerance test.
Normal.
It is normal.
It is normal.
So it is not impaired glucose.
Up to
What about the
7.8.
fasting? What about the fasting? 5.9.
Fasting normal.
Normal according to the WHO, according to the NICE. But the American
Abnormal according to
abnormal.
American guidelines.
So, and this actually is a question which is a debatable question. So according to the NICE, according to the WHO, it is a normal. But actually on the exam, answer it as impaired fasting. And actually this answer regarding the American recommendation. And actually they mentioned that this is actually a table which is important regarding the fasting as I mentioned. The fasting in normal less than 5.6, this is American recommendation. Less than 6.1 in NICE recommendation. Abnormal if more than 7. So in between 5.6 and 7 American recommendation impaired fasting like our case scenario, but 6.1 to 7, this is a NICE recommendation. So this question, if answered according to the American diabetes recommendation, it is impaired fasting. If we answer in the exam, I will answer it as a normal result. So don't forget this when you're solving some question like this. So it is very important to know this difference between the WHO and NICE, the American Diabetes Association, in this part only. This is just a few hints in the Oxford Handbook, not a very repeated question like this. And actually, in most final exams, they will not put a question like this because it is a debatable point. So don't forget that the diagnostic criteria for diabetes mellitus according to all society require fasting, 75 gram oral glucose tolerance test, random hemoglobin A1C. And we should differentiate between normal, impaired fasting, impaired glucose tolerance test, and diabetic. And don't forget that 2 abnormal result is necessary except random asymptomatic patient. First of all, random blood glucose and fasting, we have 2 different units. Unit which millimole per liter, and it is available in a lot of the countries, and another reference unit milligram per deciliter. This is for random 2 hour and fasting blood glucose. How we can convert it is very easy. If we want to convert it from millimole to milligram, please multiply by 18. And if you want to convert from milligram per deciliter to millimole, please divide by T. This is a very important hint to how to convert from millimole per liter to milligram per deciliter. Why I put this slide? Because in the final exam, you will see the result in millimole per liter. So try to be familiar with millimole per liter for the exam. If you don't know millimole per liter, please know that multiply or divide by 18 to convert from each one. This is a very important. Another very important unit for hemoglobin A1C. As you know, a lot of society mentioned hemoglobin A1C by percent, but Brecht used millimole per mole. So don't forget, in 6% hemoglobin A1C equivalent to 42. And actually to convert, you require a difficult equation like this. This is how to convert from percent to millimole and vice versa. And actually you will see a lot of the online application like this, how to convert units from DCCT to IFCC unit. And if we go to this website, which is a converter of hemoglobin A1C, you will see like this. This is a converter to convert from percent. For example, 10% hemoglobin A1C is equivalent 85.8 millimole. If you, for example, 48, it is equivalent to 6.5%. So this is a converter, how to convert between hemoglobin A1C and millimole. And actually in the final exam, nowadays, in the recent few years, they put these two units. They mentioned it by millimole, and in the bracket, they will mention it by percent. But the most important for the SC exam is millimole per mole unit. This is a very, very important. So this is a table from the Oxford Handbook, which is important to know about it. As I mentioned, in normal fasting less than 6.1, this is a WHO and NICE. In 2 hours in normal less than 7.8. A diabetic with diagnosed diabetes, if the fasting is more than 7, 2 hours is more than 11.1. And of course, in between this value, if between fasting 6.1 and 7, it is impaired fasting. In 2 hours, if fasting is less than 7, and the 2 hours between 7.8 and 11.1, it is impaired glucose tolerance. So if the patient has impaired fasting and impaired 2 hours, it is impaired glucose. Not impaired fasting plus impaired glucose tolerance test. This is important. So if the patient have impaired fasting and impaired glucose tolerance test, it will be impaired glucose tolerance test, not fasting plus impaired glucose tolerance test. Another difference, so this is the one difference between in NICE WHO and in American. Another one related to the normal hemoglobin A1C. In NICE recommend in normal hemoglobin A1C is less than 6 or less than 42. In diabetic is more than 48 millimole or more than 6.5. In between impaired glucose tolerance test or pre-diabetic. So this is a very, very important to know the number, because in each exam they will ask about a case scenario and ask it, is it diabetic or impaired glucose or impaired fasting? And they may ask a question related to the progression. This is a WHO and IDF table. And actually in this table you see another number which is not all of you know it. 12.2 millimole, which is equivalent to 120 milligram per deciliter. This is a diagnostic cutoff point for diabetes for capillary plasma glucose. As you know, fasting 2-hour post oral glucose tolerance test, random, all of this sample should be venous. But in the WHO, they mentioned a 2-hour capillary, the cutoff point is 12.2, which is equivalent to 220 milligram per deciliter. So the fasting may be venous or capillary, the cutoff point is 7. A 2-hour venous, the cutoff point 11.1. A 2-hour capillary, this is a unique 12.2. Random more than 11.1. Hemoglobin A1C is 6.5. This is a cutoff point diagnostic criteria for diagnosis of diabetes mellitus according to the WHO with IBF. This is a very, very important. And don't forget that the IDF, the fasting in normal is less than 110 milligram per deciliter. This is the same as in NICE. But in American, the normal fasting is less than 100. The pre-diabetes, as I mentioned in previous, this is the American Diabetes Association recommendation. The pre-diabetic if the hemoglobin A1C, and actually in the previous guideline, hemoglobin A1C is the third part, the third criteria, but nowadays it is not in the fifth criteria. Hemoglobin A1C between 5.7 and 6.4, this is pre-diabetic. Don't forget that hemoglobin A1C should be in standardized way. The fasting between 5.6 and 6.9 millimole per liter third fasting, the 2-hour between 7.8 and 11 millimole per liter. This is pre-diabetic. Don't forget that the risk is continuous below the lower limit of the range and becoming disappropriately greater at the higher end of the range. And this is diagnostic criteria for diabetes mellitus. And as I mentioned, actually, it is which is very important. The fasting have a specific criteria: no caloric intake for at least 8 hours. The hemoglobin A1C should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay. This is essential by using point-of-care device. Specific devices, not all devices are the same. The oral glucose tolerance test should be done by 75 gram anhydrous glucose dissolved in water, in 240 milli of water. To diagnose diabetes mellitus, we require two different abnormal values except classical symptom plus random more than 11.1. This is a very, very important. So don't forget that in the absence of unequivocal hyperglycemia, diagnosis require two abnormal results from the different tests, which may be obtained at the same time, hemoglobin A1C and fasting, or the same test at two different time points, like fasting and 2-hour post oral glucose tolerance test. This is a very, very important. So one abnormal value is not a diagnostic.
لو سمحت يا دكتور خالد، هو يعني ايه الايكوفوكال absence of unequivocal hyperglycemia؟ يقصد ده symptoms يعني ولا ايه؟
Yes, symptoms. So if we have a patient with asymptomatic, for example, no weight loss, no polyuria, no polydipsia, this is unequivocal hyperglycemia.
طب ده معناه انه لو احنا هنعتمد على الكرايتيريا بتاعت اي واحده من اللي فوق دول، لايك مثلا ال 2 hour post براندي ومعه symptoms، انا كده مش هعتمد عليها بقى، لان انا كنت بعتمد على السيمتومز في الراحه.
We should repeat another test or doing hemoglobin A1C or doing fasting. One abnormal result is not a diagnostic except random with classical symptom or hyperglycemic crisis, for example.
يعني انا ما ينفعش اعتمد على اي واحده من دول الون لوحدها الا لما يكون معاها symptoms.
No.
ده معنى كلمه
actually all values is not a diagnostic except if repeated and abnormal. If we have two abnormal value, it will be diagnostic. And the only criteria that can be used alone is a random with a classical sample.
تمام.
This table is from the Oxford textbook, and actually they summarize the diagnostic criteria according to the WHO, which is the same as the NICE. and the American Diabetes Association for diabetic and pre-diabetic. Don't forget that the fasting more than 7 is diagnostic for all society. 2 hour more than 11.1. Glycated hemoglobin more than 6.5. Random more than 11.1. The difference mainly from the fasting, normal fasting, from the society 6.1 and 5.6 in the American Diabetes Association, and the normal hemoglobin A1C, which is 5.7 in the American Diabetes Association and 6 in the NICE recommendation. And this table from the Oxford textbook, and actually I put 6.1 to know that this is WHO and the NICE. The original algorithm is not presented with 6.1. I put 6.1 to announce that in normal fasting 6.1 this is for NICE and WHO, not for other society. And this is when to screen for diabetes mellitus in a patient with obesity. The American Diabetes Association recommends testing for diabetes mellitus in all adults with overweight or obesity who have one or more of the following risk factors. This is a very, very important risk factor to know. The first degree relative with diabetes is a risk factor. The high risk race ethnicity is a risk factor, like African American, Latino Native American, Asian American. History of cardiovascular disease is a risk factor. Hypertension, low HDL cholesterol, elevated triglyceride, polycystic ovary syndrome, physical inactivity. If there is a symptom associated with insulin resistance like severe obesity, Atkins negligence, metabolic dysfunction, associated steatotic liver disease. This is a risk factor for development of diabetes and required to do screening for diabetes mellitus. And of course, if we have a pre-diabetes mellitus by hemoglobin A1C or fasting or impaired glucose tolerance test, required to test annually. This is important. People who will diagnose with GDM should be diagnosed, screened at least every 1 to 3 years. This is a very important hint. For all other people without this risk factor, we should screen from the age of 35. And the testing should be repeated at a minimum of a 3-year interval, except the GDM, we can repeat it every year. And of course, the patient with the pre-diabetes should be tested annually. If the patient receiving some high risk group category like HIV, exposure to high risk medicine like steroid, the history of pancreatitis, in this situation, the patient should be closed, monitored for screening for hyperglycemia. Let's go to another question from the Atoll book. And if you read the question head, which one of the following is appropriate indication for use of hemoglobin A1C for diagnosis of diabetes mellitus? Don't forget that hemoglobin A1C reflects RBC hemoglobin lifespan in the preceding 3 months. So any acute hyperglycemia, we cannot depend upon hemoglobin A1C. So if we have type 1 diabetes mellitus, we cannot depend upon hemoglobin A1C alone. If we have a patient with steroid hyperglycemia, we cannot depend upon hemoglobin A1C. If we have acute pancreatic damage, we cannot depend upon hemoglobin A1C. If we have pregnancy, hemoglobin A1C is not accurate. So we can depend upon hemoglobin A1C in diagnosis of type 2 diabetes mellitus. But for type 1, for steroid-induced, if hemoglobin A1C is normal, it will not exclude diabetes mellitus. This is very important. But if hemoglobin A1C is abnormal, we can use it. But if it is normal, we cannot use it to exclude diabetes mellitus. Yes, you are right. So hemoglobin A1C will not be appropriate in a patient with acute hyperglycemia, a patient on steroid, antipsychotic, pregnancy type 1, in the initially children and young adults, hemoglobinopathies, because it will affect hemoglobin A1C. If we have a short duration of osmotic symptom like type 1 diabetes mellitus, it will not be used to assess hyperglycemia with hemoglobin A1C. And actually, the hemoglobin A1C may be falsely elevated In a case of the vitamin B12 deficiency, iron deficiency, anemia, alcoholism, renal, splenectomy, asthenia, chronic opiate, and will be falsely low in a patient with reticulocytosis, hemolytic anemia, chronic liver disease, sickle, splenomegaly, pregnancy. Don't forget this, because this is a very, very repeated in the previous exam, and actually in the 2020 and the 2024 they asked a question like this. Patient on hemodialysis and have carbamylation of hemoglobin 1c. This hemoglobin 1c will be falsely low or falsely elevated. With carbamylation of hemoglobin 1c, it will be falsely elevated. Falsely elevated. So don't forget that we can write in this item falsely increased hemoglobin 1c, carbamylation of hemoglobin 1c. And actually, I put this slide. Carbamylated hemoglobin will cause falsely elevated hemoglobin 1c. Blood transfusion, which is important, and another question in the previous exam, will cause falsely decreased hemoglobin 1c. So don't forget that carbamylation hemoglobin 1c is a chemical modification of hemoglobin 1c protein that can interfere with accurate measurement of blood sugar level, which will cause falsely elevation by 5 to 10%. Because in the previous exam, they asked about the percentage of elevation of hemoglobin 1c if the patient is carbamylated hemoglobin 1c. So please write this note in your Oxford Handbook. Classification, as you know, that diabetes mellitus is classified in 4 categories. Previously, type 1 or insulin-dependent diabetes mellitus and non-insulin-dependent diabetes mellitus. But nowadays, we have different 4 categories. Type 1, type 2, gestational, and specific types of diabetes mellitus, like steroid-induced diabetes mellitus, Ilmodi diabetes, and so on. So actually, this is a more detailed histological classification of diabetes mellitus. Type 1, which is either autoimmune, which is the most common for type 1, or idiopathic, which is negative autoantibody. Type 2 due to the insulin resistance, and of course this is the most common type of diabetes mellitus, and GDM, which is a hyperglycemia diagnosed during pregnancy, and other specific type like defect of the beta cell, defect of the insulin action, problem in the endocrine pancreas, endocrinopathy like acromegaly, Cushing, glucagonoma, and so on, drug-induced hyperglycemia, infection, immune-mediated related diabetes mellitus, and other genetic sometimes associated with diabetes mellitus. Let's go to these items in more detail. Type 1 diabetes represents 5 to 10% of the cases. It is usually due to the beta cell destruction with autoantibody, but another form is idiopathic. Don't forget that if hyperglycemia is diagnosed in the first 6 months of life, this is not type 1. This is immunogenic diabetes mellitus, neonatal diabetes mellitus. Type 2, it is about 90%. This is the most common form, defective of the insulin secretion. In other specific type, like the genetic defect of the beta cell, like Ilmodi, the mitochondrial, and neonatal, as I mentioned, in neonatal, this is hyperglycemia diagnosed in the first 6 months of life. The genetic defect of the insulin action, like lipodystrophy, insulin receptor mutation, like Rapson-Menhel syndrome, leptin deficiency, disease of exocrine pancreas, like pancreatitis, pancreatectomy, cystic fibrosis, which is a very, very important cystic fibrosis. Endocrinopathy like Cushing, acromegaly, pheochromocytoma, glucagonoma, hyperthyroidism, type 1 and 2. Drug-induced like diazoxide, thiazide, HIV medication, antiretroviral treatment, and of course, steroid, alpha interferon, beta agonist, thyroid hormone. Infection like cytomegalovirus, an uncommon form of immune-mediated like Stiff-Man syndrome, other genetic syndrome associated with diabetes like Down, Klinefelter, Turner, Wolfram syndrome. Don't forget Wolfram syndrome, diabetes mellitus, diabetes insipidus, optic atrophy. اللي هو Diamond syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, diamond. And lastly, GDM. This is the fourth category. And this is the same table, but I will focus on the drug-induced diabetes mellitus, which contain diazoxide, steroid, thiazide, antipsychotic. And don't forget that tacrolimus. Tacrolimus is a very important drug that can cause diabetes in a patient with organ transplantation. So tacrolimus will cause associated with development of diabetes mellitus and in a few cases DKA. The mechanism of action of tacrolimus is suppression of insulin secretion by inhibiting the transcription of the insulin gene. So don't forget this. In the final exam, if you have a question like this is a very, very, very repeated question in the all previous exam. If we have a patient with polyuria, tiredness, and living or related kidney transplant with a good graft function, and the patient on steroid 5 mg, mycophenolate mofetil, tacrolimus, beta blocker, simvastatin. The hemoglobin A1C is elevated, rhodam is elevated, the patient is diabetic. Which drug is the most likely to be responsible for the diabetes for new onset? Which drug? Is it beta blocker? Is it mycophenolate mofetil? Is it prednisolone or tacrolimus? Please choose tacrolimus. So if we have a patient like this and the new onset diabetes, this is a very, 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 very repeat. In each year, you will see a question like this. This is the most important one. So exam lab is a very, very essential source for solving questions in the final exam. Tacrolimus, if you see this question, tacrolimus, please choose it and go to the next question. Don't hesitate your time by choosing steroid and so on. Why not steroid? As I mentioned, Dr. Muhammad, in this case scenario, steroid dose is small. And actually, if we have steroid and tacrolimus usually is the source, which, as I mentioned, this is from the DeGroat textbook. Actually, tacrolimus suppresses insulin secretion by inhibiting transcription of the insulin gene, which can cause diabetes mellitus in new onset and also can cause DKA. Don't forget that we have type 1, type 2, and mode diabetes mellitus. We have a different form of diabetes mellitus, type 1, type 2, mode, LADA, mitochondrial, amylin gene mutation, and other forms. This is a very, very important. And don't forget that mode diabetes, LADA, mitochondrial may have overlap between type 1 and type 2. So it is very, very important in the final exam to differentiate between type 1 and type 2 and other forms of diabetes mellitus. Type 1, they usually ask about the peak age of the onset. This is another question in the previous exams. The peak onset during puberty. The peak age of the onset for type 1 during puberty. Of course, the UK preference of type 1 is 0.25, but for type 2, it is about 5 to 7% or 10%. Type 1 acute presentation, type 2 is slowly onset hyperglycemic symptom. The etiology of type 1 is autoimmune beta cell destruction. The beta autoantibody is positive. But in type 2, it is usually insulin resistance with beta cell dysfunction and insulin resistance male. And actually, the presence of the beta cell autoantibody is present in type 1 in more than 90% or 95%. Another 5% is idiopathic with negative autoantibody. And I will cover autoantibody in the next Friday, inshallah, in more details, because this autoantibody will disappear with time. But don't forget, in type 2, no autoantibody. But actually, in the previous exam, they ask about the prevalence of GAD positive autoantibody in type 2 diabetes mellitus. So don't forget that. The autoantibody is presented in about 90% for type 1 but it may be presented in about 2 to 5% in the type 2 diabetes mellitus will be positive. And actually, this is from this paper published in Diabetes. They mentioned that from this study, GAD positive in type 2 diabetes mellitus is present in about 4% or 3.7% in the Europe and the North America. So in the previous exam, they asked about the prevalence of GAD positive autoantibody in type 2 diabetes mellitus, which is about 2 to 5%. Please write this in your book. So don't forget that DKA is very common with type 1, not common with type 2. Obesity is not uncommon with type 1 because obesity is very common in the general population, but it is common in type 2. Insulin resistance is a common with type 2. And don't forget that treatment. Type 1 should be treated by insulin basal bolus, but type 2 should be treated with a non-insulin therapy initially. But if there is a catabolic state, we can treat by insulin initially and then another non-insulin therapy. And of course, a lifestyle modification, diet and nutrition, exercise is mandatory for all diabetics and even for non-diabetic personnel. This algorithm is very important, and actually this algorithm from the 3rd edition, not present in the 4th edition. 4th edition have a different algorithm. This is from the 4th edition, but this algorithm from the Oxford Handbook 3rd edition. If we have diabetes mellitus diagnosed before in the first 6 months of the life, this is neonatal diabetes mellitus. If after 6 months, if the diabetes is diagnosed before the age of 45, with definite and numerical feature, we should suspect mitochondria. So in any case scenario, if you have a definite and numerical feature, we should suspect mitochondrial diabetes, which is maternal inherited diabetes mellitus. If we have permanent insulin within 3 months of diagnosis, diabetic ketoacidosis, positive antibody, this is probably type 1. If not, we should assess the inheritance. If we have more than 2 generations with young onset diabetes, we should suspect mood. Otherwise, we should suspect type 2 diabetes. Let's go to it again. If we have positive autoantibody with low C-peptide, in this situation, probability of type 1 is very high. Don't forget that the C-peptide is not mandatory, and the beta cell antibody is not mandatory if this is just in the borderline cases. If we cannot conclude is it type 1, we can do beta cell autoantibody. But don't forget that if you don't sure is it type 1 or type 2, don't waste your time. Give insulin therapy and do another assessment. So if you have a debate about is it type 1 or type 2, the patient present with catabolic state, please treat with insulin therapy. If you don't conclude is it type 1 or type 2, please treat it as type 1 until doing more biochemical testing and so on. If we have a clinical feature including obesity, insulin resistance, hypertension, dyslipidemia, hepatic acidosis, polycystic ovary, it is probably type 2. Otherwise, we should search for a classical MODY diabetes mellitus. Classical picture of the MODY, lean, with positive C-peptide, antibody is negative, strong family history of diabetes diagnosed in the young, and of course, decay is unusual. If we suspect MODY, we need to differentiate, is it glucokinase or HNF1 or 4-alpha? A glucokinase MODY, it is asymptomatic, mild fasting hyperglycemia, hemoglobin A1C usually mildly elevated, less than 58, with a family history, and of course, if diagnosed during the pregnancy, it is usually glucokinase. HNF1 alpha and 4-alpha usually require insulin treatment with sulfonylurea, respond well to sulfonylurea. CRP is negative with HNF1 alpha, macrosomic neonatal hypoglycemia with HNF4 alpha. The mitochondria, as we mentioned previously, there is a neurological manifestation, myopathy, deafness, and this is inherited by maternal inheritance. A lipodystrophy, which is a severe insulin resistance, young onset metabolic syndrome, polycystic ovary, acanthonegricans, but normal BMI and lipodystrophy. HNF1 beta, there is a renal cyst or genitourinary anomaly. This is a unique for HNF1 beta. Again, genetic is a very, very important, and every year they will ask a question related to this topic. If we see the question like this from the exam lab, this is a woman with type 1 diabetes mellitus, pregnant. The father is type 1. So the mother is type 1 and the father is type 1. And ask about concerned that their child might develop type 1 diabetes mellitus. What is the likelihood of a child with to develop type 1 diabetes mellitus if the father and the mother is type 1? What is the answer? Five to 10%, 25 to 40%. So there is a debate about which one, option B or option C. And actually, exam lab answer it as 25 to 40%, which is the correct answer for the final exam. But if you look for in William textbook, in the latest edition, they mention that the risk of type 1 diabetes mellitus if both parent is about 10%. So in the final exam, if we have a question like this, I will answer it in the exam lab because all the answers of the exam lab are correct for the exam. But otherwise, I will answer it in the William 10%. So it is very important to know this discrepancy between the references. Answering the question according to the time of the exam. So at least you need to know this. William textbook mentioned it is if the both parents are diabetics, the risk will be 10. If exam lab mentioned it is 25 to 40%. But actually, you can do another search for it and you will may find another number. So in my summary, I mentioned both numbers. It is between 10% to 40%. And actually, this wide range of percentage regarding the onset of type 1 diabetes mellitus in parents. If the father is type 1 diabetic after 40 years of the age, the percentage is different if the type 1 diabetes from the younger age. If you look for it in the literature, you will find the discrepancy according to the age of development of type 1 diabetes mellitus in the parents. So the incidence will be 10 to 40%. As I mentioned, this is a very, very, very important and very repeated in the previous exam. If the mother is type 1, the risk is 1 to 2%. If the father is type 1, the risk is double, 3 to 6%. If we have a sibling with type 1 diabetes mellitus, the risk for other children will be 5 to 6%. In monozygotic twins, the risk will be 50%. Don't forget that. This is for type 1. For type 2, the risk is more and more. For example, if the mother is type 2, if the father is type 2, the risk is 25%. In monozygotic twins for type 2, the risk between 60 to 100% for type 2. This is a very, very, very important. And of course, this is a question from the Atoll book and ask about what is the risk of developing of type 1 diabetes mellitus for a baby born to a father with type 1 diabetes mellitus. As I answered it is which percentage? This is a very, very important and very repeated question in the previous exam. Yes, it is 3 to 6%. So this table from the Atoll, which compare between type 1 and type 2 for if the mother is type 1 or the father is type 1 or concordance. Yes, Dr. Hassan.
خالد ازي حضرتك؟
يا اهلا وسهلا، اخبار حضرتك يا دكتور حسام؟ اهلا وسهلا.
Alhamdulillah.
كمل.
Regarding this point of view about ISPAC guidelines, which is have a chapter about this issue, diagnosis and classification and genetic of type 1 in children. Regarding the last update of ISPAC guidelines, they mentioned that if the father has a type 1, the chance to or the risk to have a type 1 diabetes of his child is 66 to 9%. But if the mother 3 to 5% also, if the son or spring 4 to 6% also if dizygotic twin. But if the monozygotic twin, the risk is up to 70% of the risk is of his monozygotic twin. So as you mentioned, my dear Prof, many reference about this topic regarding the risk of type 1 or type 2 of or genetic of having type 1 or type 2 diabetes if the father or mother or sibling has diabetes.
Okay, thanks, Dr. Hussein. And actually, I will focus more data about the type 1 in the next Friday بمشيئة الله إن شاء الله, Dr. Hussein. Another question from the exam lab. This is a very, very important. What is the lifetime risk of identical twin sister also developing type 2 diabetes mellitus? As I mentioned, it is more than 60%. It is 60 to 100%. Yes, you are right. So as I mentioned, for type 2 diabetes mellitus, concordance between monozygotic twins is 60 to 100%. And of course, if the mother or father is type 2 diabetes mellitus, the risk is 25%. And this question from the study BRN. And of course, this is a 35-year-old school teacher presented with diabetes mellitus since 3 years with good glycemic control on oral hypoglycemic therapy, never experienced ketosis. Sister is diabetic since the age of 12. Nowadays, it is the age of 24. Blood pressure is normal. Body mass index is not obese. Already controlled in the metformin and the glycoside, with hemoglobin A1C is 7.5, fasting 6.9, TSH is 0.1, TRAB is negative, GFR is normal, GAD is negative. Which of the following is the most likely correct diagnosis for this young man? The patient is diagnosed in the young with a family history and good glycemic control on oral hypoglycemic agent. Which one? Yes, we should suspect mood. We should suspect mood. So don't forget that Schmidt syndrome is autoimmune polyendocrine syndrome type 1. In modern diabetes, this is the commonest form of monogenic diabetes mellitus that inherited by a single gene. It represents about 0.5 to 1% of the all patients with diabetic. It is usually diagnosed in the young, age less than 45. It is autosomal dominant, strong family history, absence of autoimmune marker absence of the insulin resistance. The C-peptide is positive even if insulin treated. And of course, the most common form is glucokinase and hepatocyte nuclear factor mutation, which is HNF1 alpha for alpha 1 beta. So glucokinase and transcription hepatocyte transcription factor hepatocyte nuclear factor mutation. Autosomal dominant mean what? 50% of the children will be affected if one father is affected. Autosomal recessive mean if both parents are a carrier, only 25% of the children will be apparent. If one father is diseased and the other parent is not a carrier, no children will be affected. But in this situation, all children will be a carrier. We have a different form of MODY, glucokinase, transcription factor, neonatal diabetes mellitus, which is a type of monogenic diabetes mellitus. Let's start by HNF1 alpha. This is a very, 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 very important topic. HNF1 alpha, this is the most common form, 30 to 70% with glucokinase. It usually presents with a progressive defect of the insulin secretion, so the patient should be treated with sulfonylurea, respond well to sulfonylurea. It may be present with vascular complication. HNF1 alpha and 4 alpha present with vascular complication. It is very unique for it, low renal glucose threshold and low CRP. This is a unique for HNF1 alpha. If we have mild hyperglycemia with the glucoseuria, it is HNF1 alpha. And of course, CRP is negative. Sensitive to sulfonylurea, low dose of gliclazide, for example, is the first line therapy. The second line is metformin, DB4 inhibitor, and of course, the SGLT2 inhibitor may be less effective than type. Yes, Dr. Hussein. Schmidt is APS type 2, not type 1. HNF for alpha, which is MODY 1, is less common, 5 to 10%. Similar to HNF1 alpha, except normal renal glucose threshold and normal CRP. Test sulfonylurea, unique for it. If we have a baby with hyperinsulinemia, macrosomic baby, or neonatal hypoglycemia, it is HNF4 alpha. Glucokinase, it is the most common form if diagnosed during the pregnancy. It is accounts 70% of the MODY, mild, stable, fasting hyperglycemia, usually fasting less than 8, hemoglobin A1C usually mild elevated less than 7.5 for long duration. And if we do oral glucose tolerance test, mild elevation of blood glucose in the 2-hour assessment. Can be diagnosed at any age. The patient usually asymptomatic. During the pregnancy may require insulin therapy, and of course, the microvascular complication is not documented. No treatment is required, except during the pregnancy may require insulin therapy. It is just a marker to differentiate between different forms, Dr. Mami. CRP, if in the case scenario you mentioned that CRP is positive or negative, we can use it as a clue for differentiating between glucokinase type 1A and 4A. 4A negative CRP or normal CRP, but for HNF 1A CRP usually low. So in the previous exam in 2023, 2022, all exam, they will ask about question like this. And actually in 2023, they ask a question about MODY 2. What is the defect of a glucokinase? What the glucokinase do in pathophysiology? And of course, there is a lot of option, but actually glucokinase is responsible for phosphorylation of the glucose. Actually, in the beta cell, glucose enter to the cell through a GLUT2 receptor, and glucose will be converted to glucose 6-phosphate by glucokinase. So a glucokinase will convert glucose to G6B. So the glucokinase, it catalyzes the phosphorylation of the glucose as the first step of glycolysis in the beta cell. This is a question in 2023 exam. Again, the phosphorylation of glucose to yield G6B is catalyzed by glucokinase. Glucokinase helps to store glucose in the liver. Glucokinase is presented in the liver, beta cell of the pancreas. This is the main organs that contain glucokinase. This is a very important because another question that may be asked about the location of glucokinase, mainly beta cell and the liver. So don't forget that glucokinase mode, no treatment is required except in the pregnancy. HNF for alpha 1 alpha require sulfonylurea, 1 beta and Diamond syndrome, usually oral anti-diabetic medication unlikely to respond, usually require insulin therapy. And neonatal diabetes usually respond well to glibenclamide as a sulfonylurea. 1 beta, HNF1 beta, the clue for H1 beta is renal cyst. If you see in a case scenario, picture like Moody syndrome, and you see a renal cyst, it is a Moody 5. It is HNF1 beta, which is known as Moody 5 or HNF1 beta or renal cyst and diabetes syndrome, or CAD, renal cyst and diabetes syndrome. It is caused by a whole gene deletion. It is presented with renal cyst or genital tract malformation, pancreatic atrophy, exocrine insufficiency, hyperuricemia, raised liver function test, hypomagnesemia. But the most important to know, once you see renal cyst or genital tract malformation, it is HNF1 beta. Not sensitive to sulfonylurea, as I mentioned, it is sensitive to insulin therapy, so it should be treated with insulin therapy. Another rare form, but it may be presented as a question in the final exam, is neonatal diabetes mellitus. Beta cell, K80B channel, ABCC8, and KCNJ11. This is a type of the MODY which is presented with a neonatal diabetes mellitus. So don't forget this gene mutation, ABCC8 and KCNJ11. This is a neonatal diabetes mellitus. So don't forget this. This slide is very, very, very important. HNF1 alpha presented with low renal glucose threshold, glucosuria with mildly elevated blood glucose, with raised HDL, with raised cardiovascular risk. HNF4 beta, macrosomic baby, neonatal hypoglycemia, low HDL, low lipoprotein A1 and 2, raised LDL, and don't forget that normal CRP. HNF1 beta, renal cyst. Another summary, HNF for alpha, progressive cell decline, respond well to sulfonylurea, glucokinase, mildly elevated fasting, mildly fasting, hyperglycemia, no microvascular complication, no treatment is required except during pregnancy may require insulin therapy. HNF1 alpha, progressive decline of the beta cell, microvascular complication, low CRP, marked sensitive sulfonylurea. IBF1, this is onset after the age of 35. This is a MODY 4, which is not covered today, which is not very important. HNF1 beta, renal cyst. Don't forget neonatal diabetes, KCN11 and ABCC8, first 6 months of life and respond well to sulfonylurea. And this actually the same table from the American Diabetes Association guideline, 2025 guideline, and they, as I mentioned a different form of the MODY, and don't forget that all of them are autosomal dominant, and don't forget renal cyst, HNF1 beta, HNF for alpha, macrosomic baby, neonatal hypoglycemia, and sensitive sulfonylurea. HNF1 alpha, progressive insulin secretory defect, low renal threshold, sensitive to sulfonylurea, glucokinase, which is stable, non-progressive, elevated fasting blood glucose, typically does not require treatment except during the pregnancy may require insulin therapy, no microvascular complication, which is a very, very rare. As I mentioned, the treatment of the MODY, as I mentioned, during the pregnancy, glucokinase may be diagnosed as a GDM and require insulin therapy during the pregnancy in some situation. And don't forget that HNF1 alpha and 4 alpha can be treated by sulfonylurea glipizide during the pregnancy, if not require insulin therapy. This is a very important. And HNF1 beta during the pregnancy should be treated by insulin the same as non-pregnant female. So don't forget that glucokinase, the treatment with insulin is required only according to the specific criteria if there is a macrosomic baby or fasting blood glucose is elevated more than 125 require insulin therapy, as we will discuss in the GDM and inshallah. And actually this is from the William textbook. This is the latest edition, and they cover this slide, which is a very, very important slide. In a William textbook, the latest edition, they put this table which summarizes the management of monogenic diabetes mellitus during the pregnancy. And they mentioned that in a glucokinase, before the pregnancy, no treatment is required. During the pregnancy, we have two options. If the mother and the fetus carry glucokinase mutation, no treatment is needed. I don't know why this. If the mother and the fetus carries the glucokinase mutation, no treatment is required. But if the mother carries a glucokinase mutation, large dose more than 1 unit per kilogram per day of the insulin is recommended. And after, of course, the management, no additional management is required. Induction at the 38 week. So I say, glucokinase with during the pregnancy, if we have elevated fasting, insulin is required in this dose. What about HNF1 alpha and 4 alpha? Before the pregnancy, we have two different options. Option 1, switch from sulfonylurea to the insulin, which is preferred. Option 2, we can continue glipizide until the pregnancy and switch to the insulin during the pregnancy. This is during the pregnancy, insulin shifting only during the pregnancy, and this option is less common. During the first month, we can continue sulfonylurea as in option 2, but we can continue insulin if started before the pregnancy. In the second and third trimester, we should shift to the insulin therapy. And of course, cesarean section should be scheduled from the week 35 to 38, and we should switch to previous sulfonylurea once the breastfeeding is completed. And of course, we should monitor neonatal glycemia only for HNF4 alpha because there is a neonatal hypoglycemia and macrosomic baby. This table summarized how to manage MODY diabetes during the pregnancy, but in the final exam. In the final exam, MODY during the pregnancy usually glucokinase and should be treated by insulin according to the criteria of the GDM. If we have polyhydramnios, if we have a macrosomic baby, or the fasting is elevated, in this situation, we should treat by insulin therapy. Yes, as we mentioned, Dr. Mahmoud, and we will cover it in the GDM, inshallah. Sulfonylurea may be indicated during the pregnancy. Glipizide is categorized as category B during the pregnancy. This is the FDA approval. But NICE recommend glipizide to be used as a GDM if the patient is not is refused insulin therapy. During the GDM, the first line is lifestyle and metformin after that, if not controlled. If not controlled on lifestyle and metformin, this is a nice criteria. We should give insulin therapy. But if the insulin refuse insulin therapy, we can give glipizide. This is a nice criteria. And I will cover this in more details in the GDM section, inshallah. Medical legality, actually, as I mentioned, Dr. Mahmoud, this is a nice criteria. This is a recommendation. And actually, glipizide is category B during the pregnancy. This is the FDA approval. This is the medical legal. If we have a medical legal aspect. And actually, this is from one of the famous diabetes mellitus book. This is the international textbook of diabetes mellitus. and the main author is Ralph DeFronzo. This is how to differentiate between type 1 diabetes mellitus and type 2 diabetes mellitus and different form of glucokinase and transcription factor moody diabetes mellitus. And actually, I would like to take a 20 minutes break for Salat al-Asr. So I will take a break for 20 minutes and I will go back after 20 minutes. Dr. Mecca Reda mentioned by the American Diabetes Association, it is authorized to use gliclazide. So it is authorized. No, I don't know this. I will check for this in the guideline, American Diabetes Association. Why I will check this, Dr. Mecca? Because actually gliclazide is not FDA approved. Gliclazide is not available in the American. So I don't know, is it presented in the 2025 guideline or not? I will check it again, Dr. Mecca, about gliclazide. I am sure that gliclazide is categorized as a category B during the pregnancy, but I will check for gliclazide. Gliclazide is not FDA approved medication. I will check it again. Let's continue our discussion. And actually, this question from the toolbook and ask about a unit that is aged 6 weeks, failure to thrive, dehydrated, blood glucose is elevated with low serum bicarb, and diagnosed as DKA. And ask about a genetic mutation is associated with development of neonatal diabetes mellitus. Yes, you are right. Yes, it is. The right answer is E. Potassium beta cell K-ATP channel, TCNJ11 and ABCC8 is a responsible gene mutation associated with neonatal diabetes mellitus, which is diagnosed in the first 6 weeks of life. Of course, any diabetes diagnosed in first 6 months of life is neonatal diabetes mellitus. It is inherited by autosomal dominant or autosomal recessive inheritance. And we can classify it into 2 categories: transient, which remit within 3 months with a relapse later on in some situation, and permanent neonatal diabetes mellitus, which is due to the mutation of KCNJ11 and ABCC8 gene, which is responsible for encoding KER6.2 and sulfonylurea receptor 1 subunit of the beta cell K-ATP channel in 50% of the cases, and respond well to sulfonylurea glibenclamide. If we have this gene mutation, it will be effectively treated with a high dose of sulfonylurea, and insulin may be required to be stopped. But it is very important to know this. Actually, this have a specific protocol for stopping of insulin and shifting to glibenclamide, and it is available in the neonatal and pediatric textbook. And actually, in adult life, respond to a lower dose of glibenclamide or sulfonylurea. 20% of the KATP channel gene mutation presented with also a neurological feature, developmental delay, epilepsy, and neonatal diabetes. And another gene mutation for insulin gene mutation should be treated with insulin sensitizer or insulin therapy if gene mutation is available. Let's go to another category of different types of diabetes mellitus. This is a 25-year-old male presented with 2 months history of thirst and polyuria with minimal weight loss. The body mass index is 26 with sensorineural deafness. As I mentioned, if you diagnose diabetes mellitus with sensorineural deafness, it is usually mitochondrial diabetes with a very strong family history of sensorineural deafness and type 2 diabetes mellitus. No ketones, plasma glucose is elevated. What is the most appropriate next step in the management? Genetic testing for Moody, measurement of GAD autoantibody, test of HFE genotype, test for mitochondrial diabetes or water deprivation test to assess pituitary gland. So according to your diagnosis, if it is you suspect it is a type 1, we should measure GAD autoantibody. If we suspect hemochromatosis, we should assess HFE gene mutation. If we suspect mitochondrial diabetes, we should test for mitochondrial diabetes. If we suspect MODY, we should assess genetic testing for the MODY. If we suspect Diamond syndrome, we should do water deprivation test for diagnosis of diabetes insipidus. What is your answer? Is it Diamond or it is mitochondrial diabetes mellitus? As I mentioned, if we have sensorineural deafness, it is usually mitochondrial diabetes mellitus. Sensorineural deafness is usually associated with mitochondrial diabetes mellitus. So in this situation, we should assess test for mitochondrial diabetes. This is from the exam lab. So don't forget that mitochondrial diabetes mellitus is a rare form. Due to the mutation in mitochondrial DNA, it is inherited through maternal inheritance. Maternal inheritance means what? If the mother is affected, 100% of the children will be affected. If the father is affected, no of the children will be affected. So it will be inherited only through the mother. So it is a maternal inheritance. So it is commonly associated with sensorineural deafness. So another name is MIDDD, maternal inheritance of diabetes and deafness. It is usually associated with myopathy, cardiomyopathy, macular retinal dystrophy, CNS disease, and renal disease. And clinically should include management, cardiology assessment with interval echocardiography, audiology, which is a very, very, very important and very repeated in the previous exam. Don't forget that audiology assessment is one of the cornerstone for the in the management of mitochondrial diabetes mellitus, and also should be diagnosed by genetic testing if we suspect this. And another very important to know about this, it is usually treated by insulin therapy. In mitochondrial diabetes, this is transmitted only through the mother, as I mentioned. If the mother is affected, 100% of the children will be affected. If the father is affected, no of the children will be affected. We have a lot of disease inherited by mitochondrial inheritance, like mitochondrial diabetes mellitus, mitochondrial myopathy, liver hereditary optic neuropathy, and it is a mutation in the mitochondrial DNA. Another rare form of specific type of diabetes mellitus is genetic cause of severe insulin, especially lipodystrophy. Lipodystrophy is repeated in the exam. If we have some sort of loss of the fat in the limb and increased central and ectopic fat, it is usually lipodystrophy. Lipodystrophy due to the mutation in the lamina gene and a mutation in another B-bar-G gene mutation. So in lipodystrophy, we have a loss of the fat in the limb and increased central and ectopic fat. It is a severe form of insulin resistance, so should be treated by insulin synthesizer and insulin therapy. Another form, this is the last form, insulin receptor mutation. It is a severe insulin resistance presented with fasting, hypoglycemia, growth defect, hyperandrogenesis, young onset polycystic acanthosis nigra in a lean woman. And actually, in the previous exam, no question asked about the insulin receptor mutation. Let's summarize MODY. If we have a beta cell monogenic diabetes mellitus, it may be MODY or a neonatal or this diabetes with extra pancreatic feature. MODY glucokinase, mild fasting, stable hyperglycemia, diagnosed at any time, but in the exam usually presented during the pregnancy with mild fasting hyperglycemia may require insulin therapy. Transcription factor Moody is autosomal dominant, sensitive to sulfonylurea, susceptible for complication, and treated by sulfonylurea. Neonatal diabetes, which is diagnosed in the first 6 months of life, permanent or transient, the onset usually in the first 6 months of life. Diabetes with extra pancreatic features like ORCAD, renal cyst, and diabetes which is a modified HNF1 beta, renal cyst, genitourinary malformation. This is a very unique for ORCAD Moody type. MIDD, which is maternal inheritance diabetes and deafness, neurosensory deafness, short stature, maternal inherited diabetes and deafness, which is very important. Again, renal cyst and diabetes, HNF1 beta, renal cyst, genitourinary abnormality, hyperuricemia, hypermagnesemia, abnormal liver function. The unique is renal cyst. Mitochondrial diabetes and deafness, maternal inherited. This is a very important in neurosensory deafness, nephropathy, neuromuscular feature. Wolfram syndrome, which is Diamond, another form is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, and usually sequence is not all of this feature is present at the same time. It is usually progressive. Usually present with diabetes insipidus, followed by diabetes mellitus, then optic atrophy, then deafness. So in the Wolfram syndrome, usually diabetes insipidus initially, followed by diabetes mellitus, optic atrophy, and deafness with dilated nephropathy and degenerative neurological disease. Dr. Mecca, is it a mutation ببار gamma? Actually, mitochondrial diabetes, as I mentioned, lipodystrophy, it is usually severe insulin resistance. ببار gamma agonist biology, is it effective or not? I will cover it in some question, but usually this category of severe insulin resistance require insulin therapy. Most of medications is not effective and usually treated by insulin therapy. Another table from the Oxford textbook, Wolfram syndrome, it is inherited by autosomal recessive. This is important. The childhood onset of diabetes and optic atrophy. This is a very, very, very important to know about this. Maternal inherited mitochondrial diabetes. It is deafness frequently precede diabetes, stroke in less than 40 years in the Mellitus form. Arcade autosomal dominant, as I mentioned, it is modified, HNF1 beta. Development renal disorder preceding diabetes, and of course another form is DBED syndrome, which is autosomal dominant with diabetes and pancreatic exocrine function, and I will cover some of them later in the next sessions, inshallah. Again, from the ISPAP guideline, this is a different form of the Moody diabetes mellitus with associated clinical features the same. Don't forget that HNF1 alpha and 4 alpha sulfonylurea treated by sulfonylurea, kinase diet and require insulin during the pregnancy, HNF1 beta insulin therapy. The most important to know, HNF1 alpha renal glucoseuria and low CRP. HNF4 beta macrosomic baby neonatal hypoglycemia. This is a very, very, very important and unique for this. Another question from the Atoll book, they ask about a question about which one of the following criteria feature should raise the clinical suspicion of the Moody in this patient. Absence of microvascular complication, elevated fasting plasma glucose, low good glycemic control, low insulin requirement, multiple hypoglycemic episode. Which is should increase or suspicious of Moody. Absence of microvascular complication, is it correct? No, actually, because the glucokinase, no microvascular complication, HNF 1 alpha and 4 alpha, presence of microvascular complication. So absence of microvascular complication is not unique for MODY. Elevated fasting, no, because the glucokinase, mild fasting. Good glycemic control, not. But low insulin dose requirement in this age, 24, with a body mass index 24 year, should increase suspicious of the MODY. So it is the correct answer, low insulin dose. This algorithm from the latest edition of the William textbook. Here they mention this algorithm. If we have a diabetes mellitus, acute onset with ketone, positive GAD, and other autoantibody, this is a type 1 diabetes mellitus. If we have a syndromatic feature, like, for example, deafness, neurological feature, it is usually mitochondrial diabetes, or another syndrome according to the other feature. If we have diabetes diagnosed before the first 6 months of life, or in the between 6 and 12 without positive autoantibody, it is usually neonatal diabetes mellitus. If we have insidious onset, ketone is negative, you get autoantibody and other autoantibody is negative, C-peptide is normal at diagnosis, we should suspect type 2 or other form of MODY. If we have a high body mass index, insulin resistance, it is a type 2. Otherwise, if we have absence of severe obesity, no manifestation of insulin resistance, with a strong family history of diabetes mellitus, especially in the young, we should suspect MODY. How we classify MODY? If we have mild fasting hyperglycemia, hemoglobin A1C is less than 8, no microvascular complication, it is a glucokinase. But if we have renal cyst, hyperuricemia, hypomagnesemia, don't forget this. Actually, I think this there is a mistake in the previous table. I think this is what. HNF1 beta mentioned in this textbook. They mentioned hypermagnesemia. Actually, it is hypomagnesemia, not hypermagnesemia. This is wrong. So, as mentioned in this William textbook and other references, HNF1 beta, there is a hypomagnesemia, not hypermagnesemia. So, if we have a renal cyst, pancreatic hypoplasia, pancreatic exocrine insufficiency, genital tract abnormality, it is HNF1 beta. If we have progressive hyperglycemia, symptomatic, with impaired glucose tolerance, it is HNF1 alpha or 4 alpha. If we have high HDL, presence of glucosuria, it is HNF1 alpha. If we have low HDL, high LDL cholesterol, absence of glucosuria, it's transient neonatal hypoglycemia, macroscopic baby, it is HNF4 alpha. This is algorithm presented in the William textbook, the latest edition, which is a very important algorithm for different form of hyperglycemia. Lastly, I would like to assess genetic testing, and actually there is a diabetesgene.org, this organization, or a very important organization, and we can assess neonatal diabetes by specific criteria from this website. We have another MODY probability calculator. This calculator we can go it online, and in this calculator, in this website, we can assess in probability of MODY diabetes mellitus. For example, I will write some hint about this. If we have a patient with age at diagnosis, for example, 16 years, the patient is male, currently treated with insulin or tablet, no insulin, no treatment. The time to insulin treatment, if currently treated, not currently treated with insulin therapy. Body mass index 24, for example. Hemoglobin A1C 7.5. Current age, the patient is age 20, for example. The parent affected with diabetes, yes. ethnicity-wide. I will choose option like this. If there is a renal cyst, what is the diagnosis? Calculate. They mention 75% it is a mood. If we go to another, and we can choose another option and so on. So this is a Moody probability calculator. Everyone can try it by clicking in this website. Let's go to another question. This is a patient presented by polyuria polydipsia in the previous 6 months with strong family history of diabetes mellitus. The body mass index is 24. There is a dark pigmentation of the skin in the arm pit. This is a carcinogenic. The pH is normal, the bicarb is normal, the keto negative. Which one of the following clinical biochemical feature will support the diagnosis of type 2 diabetes mellitus over diagnosis of monogenic? Which one?
Acanthus nigricans.
Yes. If there is Acanthus nigricans, we should suspect it is a type 2 diabetes mellitus, not moody diabetes mellitus. And don't forget that this is Acanthus nigricans picture. Another question, a patient, 29-year female, presented with gestational diabetes mellitus during her previous pregnancy. There is a family history of type 2 diabetes mellitus. The body mass index is normal, 23. In the first trimester showed mild fasting hyperglycemia, 5.8. With 2 hours is 8.9. There is a mild increment after 2 hours. This should suspect which type. If we have a mild fasting with a mild increment of blood glucose after 2 hours, we should suspect moody. We should suspect glucokinase. In the previous pregnancy, it is received basal insulin, which control fasting hyperglycemia and not require insulin postpartum. What is the most likely diagnosis? Yes, you are right. It is a moody diabetes mellitus. It is a monogenic diabetes mellitus, and especially glucokinase 4. So glucokinase moody presented with mild fasting, mildly elevated 2 hours. The patient is asymptomatic, not required the treatment therapy, no complications. There is might be considered to prevent fetal macrosomia insulin therapy in this situation. So mild fasting hyperglycemia, mild 2-hour increment, mild fasting glucose diagnosed in the first trimester. The patient is not obese. Previous insulin treatment may be required with history of the GDM. And actually, this is a very important book. If anyone require more details about the monogenic diabetes mellitus, this is a Kargar book related to the diabetes associated with single gene mutation. This algorithm from it, if we suspect moody, if there is islet autoantibody positive, this is a type 1. If there is obesity and Acanthus nigricans, it is a type 2. If severe insulin resistance and lipodystrophy, it is a lipodystrophy. Otherwise, we should suspect mood. If mild fasting, it is a glucokinase and no treatment is required except pregnancy. If severe or progressive hyperglycemia, it is HNF1 alpha or 4 alpha. And of course, sulfonylurea should be used as a first therapy, low dose, then combined with DB4 inhibitor. If we have a neonatal diagnosed in the first 6 months, it is ABCC 8 and PCNG 11, should be treated with clobeclamide by specific protocol. If we have a typical diabetes mellitus renal cyst, it is a renal cyst and diabetes, which is HNF1 beta, and should be treated by insulin, and another specific form, which is a didamon, and another form lipodystrophy, which is treated by insulin therapy. Let's summarize my session today, and actually summary is the same as I mentioned in the first of the session. The diagnostic criteria of diabetes mellitus is very important, and don't forget that the fasting less than 6.1, the American Diabetes Association have a different cutoff point, and also hemoglobin A1C have a different cutoff point for the American Diabetes Association. Impaired fasting will progress to diabetes mellitus in about 10% over 5 years, and if we have impaired glucose tolerance test, a risk will be doubled. So don't forget that 5 to 10% of the individual with impaired fasting will progress to diabetes mellitus over the next 3 to 5%. Actually, I would like to revise these numbers. The best way to manage prediabetes is weight loss by lifestyle management.
دكتور
The
خالد
factors that affect hemoglobin 1C, factors that increase hemoglobin 1C, carbamylated hemoglobin, alcoholism, and deficiency anemia. Factors that decrease hemoglobin 1C, blood transfusion, hemolytic anemia, erythrobiosis, pregnancy. Glycated albumin and fructosamine reflect glycemia in the preceding 2 to 3 weeks. Carbamylated hemoglobin will falsely increase hemoglobin 1C by 5 to 10%. Tacrolimus can cause hyperglycemia. Yes, Dr. Hussein. Yes, Dr. Hussein. Your mic is mute. Sorry for this interruption. Yes, Dr. Hussein.
About this slide, my dear prof, it mean if each year, if you are impaired fasting glucose, each year we will progress to diabetes by percentage or by risk 5 to 10%. But after 3 or 5 years, percentage will be 25 to 30%.
Yes. Yes, I noticed this, Dr. Hussein, during this break of my network. And actually, for impaired glucose tolerance test, the risk mostly will be double. About 30 to 50% of the patient will develop diabetes mellitus over 5 years. Thanks, Dr. Hussein. The inheritance of type 1 and type 2, as we mentioned previously, it is very important. If the mother is type 1, if the father and mother are type 1 diabetes mellitus, the risk is between 10 and 25%. And don't forget that in the exam lab, they mentioned it as 25 to 40%. So if the question in the exam, I will answer it as in the exam lab. Modi diabetes, it is autosomal dominant condition. If we have a Modi case scenario during the pregnancy in the exam, it is usually
الصوت كان راح يا
kinase.
دكتور خالد.
What?
الصوت كان راح، كان في زميل بيسأل الجي ال بي 1 او التيرزباتايد في البري دايابيتس.
Actually, I will cover actually the GLP-1 receptor analog inshallah in the third session inshallah. The GLP-1 in the clinical practice in the American recommendation, it have a cardio protection and renal protection and so on, but in NICE it is a different. So I will cover the medications used for the type 1 and type 2 inshallah in the next and third session inshallah. So we will take a lot of data later on inshallah.
Dr. Khalid.
Yes.
My comment was about tirzepatide in prevention of type 2 diabetes, which was published in last November 2024, which was greater than weight loss in prevention of type 2 diabetes. Tirzepatide decreased the risk by 95% of development of type 2 diabetes in comparison to weight loss, which was 48, and metformin, which was 39.
Thanks, Dr. Hussein. What prevent the progression from pre-diabetes to diabetes, as mentioned by Dr. Hussein? Of course, in the exam, we should use a lifestyle modification for the NICE recommendation. This is the NICE recommendation. Other drugs, it is American recommendation. This is a very important. When we revise and we answer some question, we should put in our mind the exam. This is for the exam, and this for your clinical practice, and this is for your knowledge. This is a very important, and I will cover this in more details later, inshallah. So how to differentiate between different forms of the MOD? It is very important. Low renal glucose threshold with HNF1 alpha, sensitive to sulfonylurea. There is a vascular complication with low CRP. If we have macrosomic baby neonatal hypoglycemia, it is HNF4 alpha, sensitive to sulfonylurea with normal CRP and normal renal glucose threshold. Mild fasting hyperglycemia, it is a glucokinase. And if we look for this algorithm, actually, this is why I put this, because this will mention you HNF1 alpha and 4 alpha, very rapidly progressive hyperglycemia with time. But a glucokinase, it is prior to the normal. So in a glucokinase, the patient will be present with long duration with mild fasting hyperglycemia. But HNF1 alpha and 4 alpha, it is a rapid progressive decline of the beta cell, and the patient requires sulfonylurea to manage it and so on. HNF1 beta will be presented with renal cyst and diabetes syndrome. In neonatal diabetes mellitus, it is autosomal dominant or autosomal recessive, diagnosed in the first 6 months due to the mutation of KCNG11 and ABCC. And don't forget that glucokinase is responsible for conversion of glucose, phosphorylation of glucose to glucose 6-phosphate. Mitochondria is maternal inherited with sensory neural deafness. Lipodystrophy is severe insulin resistance due to the lamina and BPAR gamma gene mutation, and usually require insulin therapy and insulin sensitizer. This algorithm is important. As we mentioned, what you mean by low renal threshold, it means actual renal threshold to cause glucosuria is about 180 milligram per deciliter, which is equivalent to 10 millimole. In this situation, if blood glucose is less than this threshold, there is no glucosuria. But in the case of HNF1 alpha, there is a blood glucose level less than 10 millimole per mole, and there is a presence of a glucosuria. This is what is we mean by low renal glucose threshold. And this algorithm, how to differentiate between different forms, and actually we cover it in more details previously. And this is the most important: renal cyst and diabetes, mitochondria, and Wolfram syndrome. Let's finalize this session by some of MCQs, and then I will focus on the previous exam. 17-year-old male presented with 3-week history of serous polyuria, balanitis, and weight loss. What is the most next step in the investigation? If we have a patient with a symptom of hyperglycemia, what is the best test to assess? Yes.
Random blood sugar.
Random. If we have another patient with incidentally elevated fasting plasma glucose, and during reading the question, you see renal cyst. Renal cyst. Which one of the following genetic mutation is most likely based on this clinical profile?
1 beta.
Yes, 1 beta or modified or arcade. Another a question. 19-year-old male lost 2 kilograms, diabetes mellitus diagnosed since 1.5 years, random is elevated, hemoglobin A1C is 56, received the gliclazide, metformin, and father and the grandfather is diabetic, diagnosed in the young age. C-peptide is normal, hemoglobin A1C is mildly elevated, GAD autoantibody is negative. What is the likely diagnosis? Yes, it is a mood. Yes. A strong family history of diabetes. Another question, what is the concordance rate of developing type 2 diabetes mellitus in monozygotic twins? Yes, 60 to 100%. What about the diagnostic criteria or interpretation for this result? The baseline or fasting 5.9, the 2 hour is 10.4. What is the interpretation? Is it normal? 2 hour is 10.4. Yes, it is impaired glucose tolerance. Yes, you are right. It is impaired glucose tolerance test. And don't forget this algorithm, the normal fasting 2 hour and random. Random has no normal value. It is a diabetic if more than 11.1. Another question from the Atoll book. It is a patient, 40 years, presented with osmotic symptom, elevated plasma glucose, no family history of diabetes, body mass index is 22. Random is elevated, pH is normal, bicarb is normal, urine ketone negative. Which one of the following tests may be useful in establishing the underlying diagnosis? Which one? Antigen for type 1, mitochondrial, oral glucose tolerance test, serum ferritin, toxicology screening. Which one? A patient present with osmotic since 2 months with body mass index normal, not obese.
Antigen.
Yes, we should suspect is it type 1 or not by doing antigen antibody. Don't forget serum ferritin if we suspect hemochromatosis. Hemochromatosis diagnosed by type 2 diabetes mellitus, hypogonadism, liver affection, and arthropathy, and skin color.
Hyperpigmentation.
And at the end of my session today, I would like to cover the most important question from the previous exam related to the current session, inshallah. So in the previous exam, there is a lot of the question, as I mentioned, at least 6 to 8 questions from the current presentation. One of the questions from November 2024 asked about the risk of type 2 diabetes mellitus in identical twins. What is the risk? As I mentioned, 60 to 100%, more than 60%. So in monozygotic twins, the risk is 60 to 100%. This question from November 2024. Another question from November 2024, a case of gluteal lipodystrophy, and ask about its metabolic cause. Of course, this is a case of the insulin resistance, case of lipodystrophy, and I will cover it more details later. As we mentioned previously, it is due to the mutation in the lamina and BPAR gamma, and of course, treatment should be by insulin synthesizer and insulin therapy. Another question about a patient received erythropoietin and a blood transfusion, and ask about the effect on the hemoglobin A1C. As we mentioned previously, the transfusion and erythrobiosis will cause falsely lower hemoglobin A1C. The blood transfusion, erythropoietin will cause falsely low hemoglobin A1C. This is a very, very important. And another question in the same exam, ask about a glycated hemoglobin period, which assess which period of hyperglycemia. As we mentioned previously, it will affect 2 to 3 weeks previously. So it is 14 days. So don't forget that glycated albumin, like efractosamine, will assess glycemia in the preceding 2 to 3 weeks, but hemoglobin A1C in the preceding 2 to 3 months. And another question in the previous November 2024 asked about carbamylation of hemoglobin A1C. It will cause falsely, which one? Falsely elevation. Falsely elevation higher by 5 to 10%. So carbamylation will cause falsely elevated hemoglobin A1C by 5 to 10%, as I mentioned, and this is one of the difficult questions in the previous November 2024. Another case scenario, if we have a patient with diabetes mellitus and blood glucose is 7, but there is a glucoseuria. What is gene mutation? Which one? The blood glucose is 7 with glucose plus 3. Which one?
1 alpha.
Yes, it is 1 alpha. So don't forget that 1 alpha, low renal glucose threshold. Blood glucose is mildly elevated with presence of the glucoseuria. Another case scenario, female pregnant, family history of diabetes mellitus. What type of monogenic diabetes, as we mentioned previously, glucokinase, usually presented in the exam as a pregnant female with GDM, mild fasting hyperglycemia may require insulin. This is from June 2024. The monogenic diabetes is autosomal dominant. When we suspect, if we have a strong family history of diabetes mellitus in the young, absence of autoimmune marker, absence of insulin resistance, the patient is controlled with a small dose of the insulin, mild fasting hyperglycemia, the presence of specific criteria. And this table summarizes different forms of the moody and neonatal diabetes mellitus. If we have a patient, a 20 years diabetes diagnosed at the age of 3 months, asking about the type of diabetes mellitus, and this is from the June 2024. This, of course, a neonatal diabetes mellitus. Neonatal is diagnosed in the first 6 months of the life, and some form of it should be treated with sulfonylurea. And this algorithm, as I mentioned, summarize how to differentiate between different forms of the mood. If the father is type 2 diabetes mellitus, what is the risk for inheritance for his offspring? What is the percentage?
2 to 6%.
Type 2, not type 1. Type 2.
No, 25.
25. Yes, 25. So don't forget between type 1 and type 2, 25% for type 2. But if the father is type 1, the risk is 3 to 6%. Another question in the same exam, is diabetes on medication, metformin, is still not controlled, complain of the muscle atrophy, and they question may be lipodystrophy. What to do for lipodystrophy? Start insulin therapy. If we suspect lipodystrophy like this, the most important treatment in this, and actually this table from the net, the most important treatment is metformin, insulin, glitazone, GLP-1 receptor agonist, SGLT2 inhibitor. But usually in the exam, we should use insulin therapy. This is the most important to lower hyperglycemia in the patient with lipodystrophy. And of course, the Endocrine Society have a consensus paper about lipodystrophy diagnosis and the treatment. Another question from the SC exam, recall 2023, a patient of pre-diabetic and ask about the level of evidence for a prevention of a progression to diabetes mellitus. And of course, as I mentioned, a nice recommend lifestyle, weight loss with lifestyle and exercise. If we have a patient with a chronic kidney disease and there is a discrepancy between capillary blood glucose and hemoglobin A1c, why is this? There is a discrepancy because if the patient received the blood transfusion, will cause falsely lower hemoglobin A1c. If the patient has erythropoietin therapy, it will cause a falsely lower hemoglobin A1c, and so on. And as I mentioned, this is the affection of the hemoglobin A1c, blood transfusion, erythropoietin therapy, hemolytic anemia, reticulocytosis. All of this will decrease hemoglobin A1c, and some factors can cause elevated hemoglobin A1c. So there is a discrepancy between hemoglobin A1c and self-blood glucose monitoring. But don't forget that up till now, all society recommend hemoglobin A1c is the most important parameter in the follow-up of the patient with the chronic kidney disease, but with self-blood glucose monitoring. In the 2023, there is a 4 to 5 question related to the MODY and different form and the LADA and mitochondrial. And actually, this slide summarizes how to differentiate between different form of the MODY and LADA and so on. And inshallah, LADA, I will cover LADA in the next session, inshallah. LADA is a very important form of the diabetes mellitus, presented by positive autoantibody. Autoantibody, autoimmunity is increased. So if we have a positive autoantibody, it may be LADA or type 1 diabetes mellitus. LADA is slowly progressive is a slowly progressive type 1 or rapidly progressive type 2. اللادة is intermediate between type 1 and type 2. Slowly progressive type 1 diabetes mellitus may be controlled initially by oral medication, but in the short duration, it will be require insulin therapy like type 1. But don't forget that if we have autoantibody positive, it may be type 1 or LADA. LADA, autoimmunity is positive. Don't forget this. If we have a patient with symptomatic, with hemoglobin A1C is 7.1, the fasting is 6.4, is 6.7. What is the diagnosis? It is diagnosis of diabetes or repeat fasting plasma glucose. Actually, don't forget this. This is criteria for diagnosis of diabetes mellitus. We should have a different form, and according to the guideline, one single value is not diagnostic except random with symptoms. This is the only one that can be used for diagnosis of diabetes mellitus if we have a symptom, but otherwise we should have two abnormal values. If we suspect mitochondrial diabetes, of course, how to diagnose mitochondrial diabetes is simple sign, and the most important diagnostic tool is genetic testing. If they ask about the best step for diagnosis, of course, it is a genetic testing. It is inherited by maternal inheritance. There is usually sensorineural deafness. Audiology and cardiology assessment by echo is very, very, very important and very repeated. Another question asked about the best way to reduce the risk of developing diabetes from the patient with the pre-diabetes. As I mentioned, in weight reduction by lifestyle, and this question from the European Board 2023 recall. The MODI different form, how to diagnose, this is another question in 2022, and as we mentioned, this is how to differentiate between different form of the MODI. Lipodystrophy also is another question from the 2022, and actually this is a recommendation by the Endocrine Society consensus statement, diagnose and management of lipodystrophy syndrome, a multi-society practice guideline. This is a different form, and they classify lipodystrophy into different form: regional, partial, or generalized fat loss with hyperlipidemia, raised triglyceride, glucose intolerance, and severe insulin resistance. And this is how to diagnose of lipodystrophy based on the history, physical examination, body composition, metabolic status. No defined serum leptin level to establish the diagnosis. We should confirm by genetic testing, which is helpful. Genetic testing should be considered a risk family marker. Serum complement level and autoantibody may support the diagnosis, and this algorithm we suspect and diagnose lipodystrophy. Another very common question from 2022, if we have a patient on post-transplant steroid and tacrolimus, what is the cause of hyperglycemia? As I mentioned, tacrolimus, and this is the same question from the exam lab. A lot of the exam lab question will be repeated. If we have blood glucose fasting 6.5 and postprandial 7.4, what is the diagnosis? As you know, this is a case of the impaired fasting. The postprandial is normal, the fasting is elevated, so it is impaired fasting, as you know, and this slide is very important. And as I mentioned here, the impaired glucose tolerance test will progress to type 2 diabetes mellitus in about 33% in 6 years, and impaired glucose and impaired fasting, the risk will be the double, 64 in the 6 years. If we have a mild fasting hyperglycemia and during the pregnancy, we should suspect glucokinase, as I mentioned. Glucokinase is a mutation, mild fasting hyperglycemia, usually diagnosed as GDM during the pregnancy. A lot of the questions relate to the MODI diabetes in 2021 recall to differentiate between ketose prone, type 1, type 2, NF1 beta, 1 alpha, and of course, as we mentioned, this is how to differentiate between type 1, type 2, and the glucokinase and transcription factor. As we mentioned previously, LADA, I will cover it in the next session, but don't forget again, LADA positive autoantibody like type 1 diabetes mellitus. And in the type 2 diabetes mellitus, the autoantibody is positive in about 5%. الكيتوز برون diabetes, I will cover it in the next Friday, inshallah. It is a patient of type 2 diabetes mellitus presented with DKA. It is DKA or ketosis, but insulin requirement decline over time, and the patient may require oral therapy. The antibody is usually negative. The patient usually of African origin, and this is a very, very important topic. Another question in 2021, other one was a strong family history of diabetes, require insulin from the start, had renal and uterine abnormality. Once you see renal and uterine abnormality, it is HNF1 beta. But actually, in this question in 21, as mentioned here, diagnosed with diabetes in his 20, so sure it is a modified or HNF1 beta, but no HNF1 beta in the case scenario. So who collect this mentioned that he choose HNF1 alpha as it seems most relevant than a glucokinase. So it is HNF1 beta, but if we have no H1 beta is not available as an option, we should exclude the glucokinase because it is a progressive disorder. So I am with HNF1 alpha or 4 alpha according to the other parameter. If CRP is negative, is low, it is 1 alpha. If there is a macrosomic baby or neonatal hypoglycemia, I will choose 4 alpha and so on. So this is a very, very important. Identical twins, risk of inheritance, it is very, very important. This is another question from a 2021 exam recall. And of course, as you know, risk of inheritance more than 60% it is. And this question also from the exam lab, what is the lifetime risk of her identical twin sister develop type 2 diabetes mellitus if the father is type 2 diabetes mellitus more than 60%, more than 60 to 100%. Another question related to a glycated albumin which reflect hyperglycemia in the preceding which duration, as I mentioned previously, is 2 to 3 weeks. Glycated albumin, it will present the preceding 2 to 3 weeks like fructosamine, but hemoglobin A1C reflect 2 to 3 months. If the mother and father is type 1 diabetes mellitus, what is the risk? As we answered previously in the exam,
25.
they answer it 25 to 40%. In the William textbook, it is 10%. So the risk mostly between 10 to 40%. For the exam, I will answer it as exam lab 25 to 40% if this option is available. And actually, I look for the ChatGPT and ask this question, risk of inheritance of type 1 diabetes mellitus if the father and the mother are type 1, and they ask about it is between 1 to 10, so it is 50%, and 1 to 10, so it is between 10 to 50%. So I am with 10 to 40% to remove this debatable point. If we have fasting hyperglycemia, which Modi, of course, mild fasting hyperglycemia, it is usually glucokinase, and this table summarizes this topic. And actually, this is the last question in my session today. In the 2020 exam recall, they ask about a question, diagnostic criteria of blood glucose. If we have impaired fasting glucose or impaired random or fasting. The fasting plasma glucose is 6.4, in 2 hours is 7.6. Is it impaired fasting or impaired glucose tolerance test? Of course, the fasting is more elevated, but in 2 hours is normal. So this is impaired fasting plasma glucose. So don't forget that again. In normal fasting plasma glucose is less than 6.1. The American Diabetes Association have a different cutoff point. In normal 2 hour post-oral glucose tolerance test less than 7.8. In diagnostic for diabetes fasting more than 7. In 2 hour more than 11.1. In between impaired fasting and impaired glucose tolerance test. And also hemoglobin A1C is used as diagnostic criteria for differentiation between fasting and diabetic and pre-diabetic and normal. This actually is the last slide in my session today. Inshallah, in the next Friday, I will cover assessing a newly diagnosed of diabetes, expert management of type 1 diabetes mellitus, and inshallah, I will cover this based from the Oxford Handbook. So for everyone, my course, please revise this items. Please repeat my today's session and write a hints in your hard copy of the Oxford Handbook, and please read this again for the next session, inshallah, in the next Friday, from the page of 850 to the 859 from the Oxford Handbook, the 4th edition. If anyone want any question, it is a welcome. Thank you, Dr. Hussein. Inshallah, أشوفكم على خير in the next Friday. And thank you. Inshallah, today I will upload the PDF file for my presentation, and I will upload the record for this session after a few hours, and I will send it to subscriber in this course. أشوفكم على خير ولا تنسونا في الدعاء. السلام عليكم.
عليكم السلام. جزاكم الله خير.